to repeat here is the chronic changes in the bone. So you get the destruction of the joint space, but you also get bony erosions, and the tophi are what are building on top of that. What's involved are the osteoclasts and the osteoblasts get out of line, and so it's written there for you. The osteoclasts get activated, and so here you've got usual osteoblasts, osteoclasts, but here you lose osteoblasts, get damaged and destroyed in the process, and the osteoclasts are then kind of free to do their job, and so that's what leads to the bone erosion. So let's go on down to general health, diet, lifestyle. So overall recommendations are going to be what you would tell anybody. Eat a healthy diet, don't smoke, eat less fat, exercise, stay well hydrated. Probably helps here. Again, in terms of diet, limiting organ meat if that is a predominant amount of their diet. And avoiding high sugary and high fructose containing products. Alcohol limiting or staying away from it, particularly. I have not seen meals so much if patients describe before they have a gouty attack, but alcohol I certainly have, even mild amounts bringing on attacks. It may be that the meat intake takes longer. I don't know. Taylor, do you have any opinion there? I don't know if it's a time delay or not. So how are people going to be presenting? When they come in, how will you be starting to think gout? Pain. They cannot stand on the foot. Usually they cannot get a shoe on the foot. So extreme walking is difficult depending on what joint's affected. Anything else they might complain of?
To touch. Just very sensitive to touch.
Sensitive to touch. Yeah, I can't have the sheet on it, so. All right, so they'll tell you rapid onset, so this is usually within a day. They may have some patients, once they've had attacks, will be able to tell earlier on that that's what's going to take place. Let's see. So and one thing to ask them is, has it happened before? Because if it has, then that may help you in discerning if it's not the first attack. And then x-rays would be consistent. If you can get an aspirate, good luck. Ruling out infection, particularly if you get to use of steroids, we want to do that before. So initial treatment, the sooner you treat, usually the shorter the attack. So long attacks, and most of the time these are going to last anywhere from a few days up to about 10 days is usual duration. The attacks will go away if you do nothing, but they won't be able to stand it. We never tell people, just go home, rest, put ice on it, it'll go away. It's too hard, too painful. But they will resolve on their own over time. Joint rest, icing the joint is appropriate. So gout is managed in 3 stages. So I'm on the middle of page 10. So there's managing the acute attacks or the flares. You could talk about them either way. Providing prophylaxis to prevent a flare. Okay, so that's what your allopurinol is. Lower the excess stores of urate to prevent flares of gouty arthritis and prevent tissue deposition. So allopurinol will do that. And then we have the probenecid will do that. And then some of the other agents we'll talk about that aren't used very commonly. Okay, so let's talk about an acute gout management. So the goal of therapy is to relieve the pain for the most part and the disability that goes with it. I'm going to skip the next part because it's pretty much, I've already said that. Let's see. So one of the principles is usually we're going to use some type of anti-inflammatory. We're going to use non-steroidals, glucocorticoids, or colchicine. Those are your 3 anti-inflammatories. Usually you're going to treat until they become symptom-free and then a couple of days past that. That's just across the board. Okay? So treat until symptom resolution and then a couple of days past that. Because some of the drugs, if you stop too early, like with the steroids, you'll get rebound. So usually a couple of days past all resolution is a good model. Okay, so let's look over on page 11. Just like everything we talk about, you'd always want to know what are the other comorbidities, because some of these drugs, like if it's non-steroidals, what are you going to be looking for if that's what you would use? What are we worried about the person would have and whether we would use non-steroidal or not? Renal disease, GI, pardon? Blood pressure, possibly, what?
Cardiac.
Cardiac disease. What's the other? First thing, how old are you? Old. Age. Sorry. Okay, so age. All right. So medications for the acute attack are there. Glucocorticoids, you've got multiple ways to use them. So you can use them orally. You can use them intra-articular, so you can inject a joint. Or you could do IV or IM. Those are least likely to use. Sometimes patients are admitted for multiple joint involvement, or they'll have a gout attack while they're in the hospital. So that might be where IV would come in. IM is usually the last route that you would use. But sometimes people overlap IM and PO. They may give them an IM to start while they start taking the PO. Non-steroidals are very common, been around forever, probably the first drugs that were used for a gout attack, indomethacin, probably 50 years now. Don't use aspirin though. So, and now you know why, because you'll make it worse. And then colchicine, also another very old drug, probably 50 or 60 years old. So let's look at the corticosteroids. This is a very reasonable choice, very powerful anti-inflammatory. Looking at the intra-articular, if people have one or two joints, this would be a choice. But you've got to make sure you're not dealing with a septic arthritis or a septic joint. Usually the glucocorticoid that's used is triamcinolone. It's readily available, lots of different strengths. Usually dose is based on size of joint. So the bigger the joint, the higher the dose you use. Usually it works pretty quickly, but there is a delay. You have to tell people it isn't going to be instantaneous. It isn't like we're putting lidocaine in here and it's going to go away, numb it right away. So tell them to expect ongoing improvement over about a 24-hour period. Oral is also an option, probably more likely you would use that than the intra-articular. So these can be used for any presentation of gout, unless you've got an underlying problem. If you give them to people with diabetes, it's going to make their blood sugar worse. So with oral dosing is about 30 to 40 milligrams. You can give it once a day or you can split it up. Often they'll split it up, especially if it upsets people's stomach. We usually like to give it early in the morning, and why is that? Why do we recommend to patients take your steroid in the morning? Cortisol level is highest, so why does that matter? Why? Natural cycle, but why would they then dose on top of already got high cortisol? Okay, so we're going to avoid some of the side effects like insomnia, but you're not hitting the big thing.
So your body doesn't try, like if you dose in the evening, then your body thinks you have enough, so your intrinsic mechanism?
So it's the negative feedback on the HPA, on the hypothalamic pituitary axis. If you give it at night, there's the negative feedback and it's going, okay, you got enough, I'm not going to make as much. But if you give it while there's already a lot being made, a little bit more, it's like spitting in the wind, it doesn't care, okay? Just a drop in the ocean that's already going on. So we usually give it in the morning to decrease suppression of the axis. Okay, so usually the taper, so we're going to taper it over a 7 to 10 day period. The problem with steroids is that rebound effect is common. So sometimes people then will taper longer, over 3 weeks. Well, to me, that really gets into a lot of therapy. But it is an option. Keep in mind, it's the one, usually don't see rebound with the non-steroidals or with colchicine. IM, again, can give it IV. IM, again, is least preferred, not a go-to. Would be if you didn't have any other route available to you, or you could do a combination of IM, 1 dose, and PO. That table at the bottom is just a summary. Okay, so steroids are one. Next page, non-steroidals. Again, indomethacin around forever, and was quite a breakthrough when you could do that. So if you don't want to use a steroid, non-steroidals are a very good option. Now people know they may keep them at home. They can go out and get them over the counter. So keeping that in mind, that people can self-treat. That would be for naproxen and ibuprofen. The other 3 are prescription. Big problem with indomethacin is it causes lots of fluid retention. It is a bad one to precipitate heart failure in people who are prone to it. So I think most people stay away from it in older folks. The rest of these are reasonable options. So again, remembering the age of the person and other kidney disease, renal disease, active GI disease, all of those things you would want a history on before you started, just like you would any time you use a non-steroidal. These ought to be emblazed in your brain. You ought to be able to be asleep and I can wake you up and go, non-steroidal contraindications, and you can pop them back right to you. Okay. It's important because they're commonly used and they commonly cause problems. Okay. Now note this. Best if you start within 48 hours, because the longer you let that inflammation go, the longer it will take. It's like the horse is out of the barn, you're trying to catch it. So it will not be as, it'll still work, but it won't be as effective. Or it'll take longer. So here you might want to do a steroid. Don't use aspirins, we talked about that. Avoiding non-steroidals, we've talked about that. It's there as a reminder for you. Here you want to use the top of the dose line. So whatever the maximum recommendation for a non-steroidal, that's where you're going to start. So this is one of those times. Usually when we're talking inflammation, we usually start at the top. Have you noticed? Okay. We didn't with the biologics, but when we're talking about an acute inflammatory, we're usually going to start high and then titrate down over time. I've got down there, should be start within 12 to 24 hours. That would be best. And you see the 48 up there? Okay, so the takeaway is the sooner the better. No one non-steroidal is preferred over the other. They'll all work. If you're going to use a non-steroidal, consider using a proton pump inhibitor because you're going to use it for 10 days or so. So it would be appropriate to use it with a PPI. If you'll look under Celebrex there at the bottom, note the dose here is much higher than what we use for other inflammatory arthritis. So this is about double the dose. So an 800 milligram at the first dose and then 400 BID afterwards. So the usual dose is 100 to 200 milligrams twice a day, so quite a bit different. And that you could use in people who are really high risk for GI problems. Questions about those? Did Dr. Vanetti even talk about those? Colchicine. Okay, here is his favorite. Wonderful drug. Very hard. So I love this drug. I love how it works. But I would never want to have to take it. Okay. So if you look up here, so this is just a cell, any cell. So, you know, I think lots of times we just think of cells being flat blobs, you know, that's kind of the way we see them, and so we don't think about them being 3D structures. Well, if they didn't have some type of cytoskeleton, they would just be little blobs, but they are 3D entities. They have microfilaments, microtubules, and these intermediate filaments, and that gives the cell structure. Okay? It also helps the cell move. So when a white blood cell is just hanging out somewhere, you know, somewhere in the body, it's in the bone marrow, just kind of waiting, and the alarm goes off, it's got to move, right? Chemotaxis. It has to get to the site of inflammation in about 12 hours. How does it do that? Well, it uses these microtubules to form pseudopods, and then, you know, kind of flows. Remember amoebas? You ever watch 4-year-olds play soccer? To me, it's amoeba ball. Here's the ball, here's the team, all around it. Wherever the ball goes, the amoeba flows. Okay, same thing here. So it's using those tubules to perform projections that the cell can then flow into. What colchicine does, it is a mitotic spindle poison. But one thing it does is it disrupts the ability for those microtubules to work, to form the proper formation to then allow the cell to move. So that's why you need to use it within 24 hours. If you don't, they're already there. So it does, now it can help with phagocytosis since the cell has to move around an entity to engulf it. You can slow that down. But your best response will be within 24 hours. If you're past that, you might think about something else like the steroids. Okay? So that's what it does. It diminishes the ability of the cell to move, and then it disrupts its phagocytosis. We haven't talked about any other any other drug doing that, right? Okay. So the problem with it is that it's really hard on the gut. It causes diarrhea and nausea and vomiting. Now, very cruelly, when I was in your place, what we used to do is we would give people 0.5 or 0.6 milligram tablets. We usually give them 5 of them, and we told them, keep taking it every 30 minutes to an hour until you get diarrhea or you throw up. How's that for an end point? Okay, we don't do that anymore. Those are high-dose regimens. 80% of people could not tolerate it. I mean, they would take it, because I don't know if you got this bad foot versus diarrhea, which one are you going to choose? It's like the two evils. Which one are you going to take? Okay. So now we go with low-dose regimens. That's the preferred. And there's several things here to keep in mind. I think they're listed on the next page. Skipped, I'll come back. So on the top of page 15, it's got these listed out. So if someone's not taking colchicine for other reasons, and we'll talk about that, you're going to give them 1.2 or 2 little tablets. It comes as a 0.6 milligram tablet or capsule. You give them 2 of them, and in an hour you give them a 3rd one. And in a 24-hour time period, that's all they get, 1.8. Then you can start them on taking 1 or 2 every day until the flare has resolved. Or some people will go with 0.6 3 times in the 24-hour period. Okay? Know that. Now, we try to keep, in a low-dose regimen, we try to keep the total daily dose in 24 hours at 1.8. Some people are going to be on colchicine long-term. So let's say they come in and they tell you so people will have flares on top of maintenance medicine. So if they come in and they go, you say, okay, what are you taking for, they come in and go, I think I'm having a gout flare. Okay, so what do you take? I take colchicine twice a day. So you're going to find out for them, how much have you taken today? 0.6, okay, we're going to have you take another one right now, and in an hour we're going to do one more. Okay. So if they're on colchicine already, you're going to take into account what they have had, and then add to that, try to stay within that 1.8 for the 24 hours. Okay? Got it? Okay. All right, let's go back to page 14. Contraindications, here's the big things to worry about. So using them with 3A4 inhibitors greatly increases their toxicity. Another type of inhibitor that we really haven't talked much about are these P-glycoprotein inhibitors, or P-glycoproteins. They are in the gut. They are transporters, like we talked about urate and oat. These are transporters that move drugs into the gut and out of the gut. Okay. A lot of these drugs are also 3A4 inhibitors. You'll notice them. Amiodarone, the calcium channel blockers, the macrolides. So keep the big thing in mind. 3A4 inhibitors, P-glycoprotein inhibitors. Keep those two in mind. If they're on those, you need to avoid or move on, especially if they've got renal or liver impairment. Place in therapy. Okay, Dr. Van Natta told me this. He said internists love colchicine. Okay, it's not a bad drug if the person can tolerate it. And it works quick if you get it in soon enough. Okay. So if they got contraindications to NSAIDs, you can use that. We did it quite a bit in the diabetes clinic as we used colchicine because we had people with renal disease and the complications of diabetes. So you can use it in people who have kidney disease or active peptic ulcer disease or a history of non-steroidal intolerance. So think of it as an alternative. But it can be first line. If you work with it and you decide, I like this drug, then use it. Just be careful in the people who you should know your contraindications. Okay. So getting it in 24 hours. Notice the theme that we've talked about. Okay, next page. It shows you, gives you a visual of how the dosing should go. If they have severe renal, if you're getting into renal stage 4 or 5, then you can increase the time between doses, is what that fourth bullet is saying. Severe liver impairment, also increasing the time between doses. At the very bottom there, combination therapy. If you've got lots of joints that you are dealing with, you can use combinations, and they're listed there for you. Almost any of these can be used together. Colchicine and non-steroidal, oral steroids, colchicine. They work by different mechanisms, so it would be appropriate. Or an intra-articular plus colchicine or a non-steroidal. All of those work. Most of the time you won't have to do that. Okay. Question about an acute attack. Anti-inflammatory time is important. Contraindications or medical comorbidities are important. Treating long enough to take care of the initial inflammation and treating past it so the rebound doesn't occur. Okay. All right, so on page 16, we're talking about prevention. So when people start having multiple flares, now usually people look at 2, and you've got 2 or more flares in a year, then we're going to start you on prevention. So we want to do something to prevent those flares from occurring frequently. See the mindset? We're preventing flares. So I'm telling you, as you all get older in your profession, it's going to shift. They're going to shift it to preventing an ongoing chronic inflammation is what it's going to shift to once we have the drugs that'll do that. So indications for under B, pharmacologic uric acid lowering. If they've got Tonify, there is no way to do it except to try to mobilize the uric acid out of those depots. Okay. If they've got signs of chronic arthritides, that would be another reason. If they've got kidney disease, you want to make sure they're not going to deposit that uric acid in their kidneys. If they've got kidney stones that are uric acid. And here's where they're big excretors. Again, most of the time you're not going to know this unless you do a workup. Pharmacologic therapy, you're going to treat to a target, and the target is you want their uric acids less than 6. Now, why would we want that? So it doesn't precipitate out. So if you get it below the solubility, saturation, solubility, then it shouldn't do that. However, uric acid levels don't always are equivalent to what goes on in those joints. So, but it's what we have right now. So below 6 in most people, if they are really having severe problems, you could go less than 5. And that is doable with the drugs that we have. First line are the xanthine oxidase inhibitors. That's what Dr. Venata was telling you. Because they get rid of the problem. They inhibit the ability to form uric acid. So we have 2 on the market. There's allopurinol. There's also Uric or febuxostat. You need good renal function for this to happen. So let's look at allopurinol. Allopurinol is usually dosed once a day. It has a very long half-life, oxypurinol, and it is more than 24 hours. So for the most part, when the doses that you're going to be using, 300 a day or less, it's all in there. I'm just going out of order. It's going to be once a day. Okay? But we never start at 300. We start at about 100. Now, why would we do that? If I stop all the uric acid that's being made, what's going to happen? Serum levels are going to fall, right? What's the Tonify going to do? They're going to start dissolving. And then what happens? Uric acid levels will go up and they will precipitate out somewhere else. So what he told you about so we're going to start low so that we don't precipitate another event. Okay? So if you are starting somebody on, and so you all brought up, I think Hannah said, don't start this when they're in acute flare. That's why. You'll just make it worse. And you won't know, is it ongoing disease or not taking their drug. So if you've got an acute flare, you want to resolve the acute flare, and then you go, you know what, you've had 2 in the last 6 months, we're going to move you to preventative therapy. Then you're going to go, then you can start the allopurinol. Okay? That's why. You'll just make it worse. And when we start allopurinol, we're going to start low so that we don't precipitate another flare as we mobilize the uric acid out of those tophi. Okay? Then you can start to increase the dose. Usually most people will take about 300 to 400 to get their uric acid under 6. The higher it is, they may take more. Okay? So increasing the dose about every 2 to 4 weeks. Okay, so when you start a preventative agent, you're going to add a drug to prevent acute flares. So we start allopurinol, and we are also going to start them on either colchicine or a non-steroidal. And we're going to do that for about 6 months, particularly in people who have tophi. Even if they don't have tophi, they've got deposits somewhere. So because we know that as we start that medicine to help dissolve those deposits, their risk of flare is very high. So we're going to put them on preventative for flares, prophylaxis against a flare. So we're going to start them on allopurinol, and we're going to put them on either colchicine twice a day or a non-steroidal low dose for 6 months. At least 3 months, usually 6. Okay? Have you got that? You've got to have those 3 concepts down. How do you treat a flare? Don't start a uric acid lowering agent until the flare is resolved. And when you start the uric acid lowering drug, you're going to add a drug on, use an anti-inflammatory for 3 to 6 months to prevent a flare. Those 3 scenarios you have to have nailed down. I will ask you, I guarantee you, because they're the important concepts. Okay, everybody got it? Make sense? Okay. All right. Next page. In the middle of 17, that's what they're describing, that acute gout prophylaxis they're going through using a nonsteroidal or using colchicine. So I'm not going to go back through it. Next page, 18. This is more about the xanthine oxidase inhibitors. A couple of things with allopurinol. Usually well tolerated. The problem with it, if you look under adverse effects, is it can cause a rash and hypersensitivity reactions that can be fatal. HLA testing needs to be done. Remember when we talked about anticonvulsants? Here it is again. This is for HLA-B 5801. The people who are most at risk are Han Chinese. Most Chinese are Han. Korean, Thai. Those are your three groups that should be tested, particularly if they've got renal insufficiency. If they are positive for that antigen, do not use allopurinol. Febuxostat or Uric is another xanthine oxidase inhibitor. It works exactly the same. It is a lot more expensive. Consider it an alternative if they cannot take allopurinol. Here's a fourth little concept at the bottom of that page. If the person comes in and they are on maintenance therapy, let's say they're taking allopurinol, they come in and they are having a gout attack, do not stop the allopurinol. Treat the flare on top of it. Okay? So that's rule number 4. One thing that has come out about Uric is that the FDA issued a warning this year about increased risk of cardiovascular disease in people taking Uric. So if you've got somebody at high risk, you might want to consider using a different agent than the Uric. They compared it to allopurinol, and cardiovascular deaths and all-cause mortality were higher with Uric than it was with allopurinol. Questions? This is a busy slide. It's probably a little bit different, but similar to what you're in. Uricosuric. These are agents that interfere with the transport systems in order to get to excrete more uric acid in the urine. Probenecid has been around forever, 50 years, long time. First line, it's usually an alternative. We usually don't go to the uricosurics because most of the people you're going to see that need one are going to fall into a category that they can't use it. So if you look down through there, under roll-in therapy, should only be used in younger patients. You won't see that many younger people with gout. Some, but not that many. So less than 60. The reason for that is you got to have good renal function. If you don't have good renal function, you're not going to excrete the uric acid, right? If your filtration rate is down, less uric acid goes into the urine. So you might as well use allopurinol to decrease its production. So creatinine clearance greater than 60, under 60. Age under 60, creatinine clearance over 60. No history of kidney stones. They don't have to take aspirin or diuretics. That's why you just don't see it very often. Dosing is listed there. It does say don't use it in patients with a creatinine clearance under 50. You can change it to 60. It's just easier. It won't matter. Drug interactions are the high-dose aspirin for reasons we've already talked about. Again, if they're on probenecid and you see them for acute gout attack, you keep taking the probenecid. Next page. that Zurampic is another uric acid. It would be a second line. It is never used by itself. It's always used in combination with allopurinol or a xanthine oxidase inhibitor. That's the big thing to remember with that. So if you could, and it's all the same things that we just saw with probenecid, except it does have an indication to treat a creatinine clearance down to 30, even though it won't be as effective under 60, which probenecid is the same thing, it just won't be as effective. So you see it works on those urate 1 and OAT4 transporters. If you look under that big discussion about Zurampic and Dazolo, you see losartan. What is losartan? Blood pressure, what class is it in?
ARB.
It's an ARB. It has a mild uricosuric action. So if you've got somebody who's got a somewhat elevated uric acid and needs an antihypertensive agent, you might think about losartan. What about fenofibrate? What's it for? What type of drug is that? Fibrate, fibric acid derivative. Lipids. Okay, so it's a drug, usually use them for triglycerides. So it also has. So because these are commonly occurring diseases together, then you might kill two birds with one stone. Next page, page 21. Krystexxa is a drug you're not going to see very often, but if you have somebody who has really high, or they've got multiple tophi, this is a drug that inhibits uricase. So it, acts like uricase. So it helps to, over there on the top side, it helps convert uric acid to allantoin, which is very water soluble and the kidneys can get rid of. So not first line, it's reserved for gout prevention in people with severe disease, refractory disease to like the xanthine oxidase inhibitors. It is given IV, given every 2 weeks, so they're going to have to come into the office to get it done. After about 6 months of therapy, about half the patients will respond. If you look down there at the bottom of that page, this is supposedly a hand of a man who took it. And you'll see the tophis in his fingers in A, and what after Krystexxa therapy, most of those were gone. Note under contraindications, G6PD deficiency, can't use the drug. Because this drug can mobilize uric acid, you have to also treat it with a preventative agent like colchicine or nonsteroidals to prevent a flare. Questions about it? On the last page, because I told you about the interleukin 1 beta, there is a drug that's on the market called Polaris. It is for other anti-inflammatory problems, but it is it's an interleukin 1 beta inhibitor. So there is investigation, so it's a drug on the market, but investigationally they're looking at using it for treatment of flares. And it is a one-time sub-Q dose. So that's pretty nice. The other is anacrina, the Kineret. It is an interleukin 1 receptor antagonist, and it's been around a little bit longer than Polaris, so it's been looked at for a while. Also acute flares. It's sub-Q. Most people are treated for about 3 days. I think this is where things are going to go. I think this is what you all will see over your lifetime. Questions about those? Yes?
What are these drugs used for normally?
Oh, all kinds of different inflammatory diseases. They're not very common, but it would be other like arthritides or other, I can't even tell you all of them. If you want, I can send you a list. But, okay, I did if you'll go to that whole tab, I've got a post-lecture quiz. So we're going to use our Retrieval genes. Okay, poll everywhere. Nancy Latassi. 946. You should see a gout post-lecture. Since you had already tested over, I think you're probably going to do well. Has anybody gotten there? It should be active? Okay. Many need more time. Sometimes I can't tell. Y'all move on to other stuff. I can't tell if you're done or not. It's cold today. Okay, everybody done? Ryan, you done? Okay, no problem. Tom, are you done? Okay. Taylor, are you done? Done? Okay. See what we do. So, condition caused by monosodium crystals, we got 100%. Okay, I'll tell Dr. Benelli. Listen. Hyperuricemia, 6, so we've got some 7. Jen, is that you? Okay. We'll go with 6 for the test. I understand that 7 is also considered this. Joint most commonly involved, big toe, good job. Uric acid is the end product of purine metabolism, good job. Which of the following foods? You've got alcohol, good. Major route of excretion of uric acid is kidneys, good, 100%. Low-dose aspirin can increase uric acid by blocking urate 1 in the proximal tubes. No, it's the OAT for the low dose. Primary cytokine is 1 interleukin beta. Okay, most of you got that one. In treatment of acute attack, NSAID should be continued for at least 2 days after symptom resolution. Some of you put until patient is asymptomatic. Yes, but then 2 days beyond that. To be effective in an acute attack, colchicine should be started within 24 hours. Know that. Know those time frames for those drugs. Maximum daily dose of colchicine in the first hour of treatment is 1.8. Know that. You give 1.2 usually, and then you give the other 0.6 1 hour later. First hour, the dosing is 1.2, and then 1 hour later you give 0.6. So it's 1.8 in the first hour. Yes?
I'll accept that as correct, but it
Thank
says
you.
no more than 1.8 per day.
Right.
And so, okay.
Right.
But, and you
So
did it all in 1 hour.
that, okay, if you look on that page that outlines it, day 1, day 2, it says first hour 1.2, and then you give 0.6. That's preferred. Now, that is referring to that you have brought up is that if they're coming in on the drug already. Okay. So let's say they've already had, they're coming in, they're taking colchicine 0.6 twice a day. And they said, I've already had both my doses, then you give another 0.6. That's where that 1.8 could come in for a total rate. Okay, good. I'm glad we clarified that. First line agent for prevention of recurrent in a 65-year-old man is what? Allopurinol. One of you took Polaris. Their insurance probably wouldn't pay for it, but it would work, should work. Allopurinol is initiated to prevent recurrent gout in which of the following is correct. Co-administer an anti-inflammatory agent with it, right. Some of you put add a proton pump inhibitor. When would you add the proton pump inhibitor? Yeah, the NSAID. Okay. So if you're doing allopurinol, you want an anti-inflammatory with it. And Krystexxa works by converting uric acid to allantoin. Okay, do these help?
Yes.
All right, good job. Y'all did well. I will tell Dr. Banana you really did know your background, so very good. All right, I'll see you on Thursday.
Thank you.
I'll figure out how to do this.